Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hi, I'm Dr. Mark Sims here. I am the host of Listen Up podcast, where I feature leaders in healthcare. This episode is brought to you by Listen Up Hearing Center. At Listen Up Hearing Center, I help patients to effectively treat their hearing loss so they can remain connected and socially in touch and be able to remain independent. The reason I'm so passionate about hearing loss is because I lost my brother Robbie twice. I lost him first to the progressive hearing loss he had from radiation to his brain tumor, and then when he was lost to complications from the treatment of that brain tumor. I'm unfortunately intimately aware of the impacts of hearing loss. I am an ear, nose, and throat doctor who only treats ears. I am the E of ENT. I've treated tens of thousands of patients for their hearing loss and performed well over 10,000 surgeries. And I'm very passionate about making sure people have their hearing diseases well treated. I am very excited. I've also to have a guest here that I'm going to tell you a little bit about more. One of the things you can look at is a book I've written. It's called Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. You can learn more about that at listenuphearing.com. I'm very excited for today's guest. It's going to be great. It's Dr. Elizabeth Heinrichs-Graham, and she's the director and principal investigator of the Cognitive and Sensory Imaging Laboratory at Boys Town National Research Hospital. We've met a bunch of the researchers from that institution. They're doing great stuff. She obtained a Bachelor of Science in Psychology from Creighton University and a PhD in Neuroscience from University of Nebraska-Omaha. I'm really excited to have her as a guest here. Welcome to the podcast. Thanks for coming on.
Thank you. Thanks for having me. I'm excited to be here.
This is great. So as you know, right now, and I think going forward, probably in perpetuity, there's a lot of interest, work, research in the connection between hearing and cognition. Okay. And so you're at a great intersection, but let's back up a little. You studied psychology and then neurosciences. So tell me how you got into that, and then we'll see how you either merged or veered or somehow took a direction to hearing.
Perfect. Yeah. So I was always interested in cognitive psychology and cognitive neuroscience. I'm a cognitive neuroscientist by training, 100%.
Can you define?
I study how the brain works and how the brain makes us think and make decisions.
Right.
So,
that's
the intersection.
Everybody, right? So,
yeah.
We toss around a lot, but yeah, that's great. Thank you.
Yeah. And it's kind of different than a lot of people study like biological mechanisms without thinking about how people think. And other people think about how people think, but don't think about what the brain's doing when you're doing those things. So I kind of intersect the two, where I study the millisecond progression of the brain dynamics that give rise to really complex cognitive constructs. So I kind of marry the two. My PhD
you're on the spectrum from biology to philosophy to spirituality.
Exactly.
Right?
Exactly.
And when I talk to people about that, when we start getting into, I'm sorry to interrupt, but the mind body is like, you have to understand this starts to become a philosophical, spiritual issue, not just a biological issue. But I'm sorry.
Yeah, absolutely. But my PhD was actually studying motor control and Parkinson's disease. So I was an expert in healthy aging and the effects of pathological aging, especially in the context of movement disorders. So it's a far cry from what I do now. But during my postdoc, I started studying child development, and a lot of that, the interest was, I saw all these ginormous differences as a function of healthy aging, but I really wanted to get to the root of where those differences started. So, as early as I could go.
Start at the beginning and go all the way up.
Yep. So I'm really interested in lifespan cognitive development and decline.
So did you have to study motor development in children, right? Because Parkinson's is a degeneration of motor function, and kids aren't born walking, for instance.
Yep. So during my postdoc, I studied the development of complex motor behaviors and motor coordination, things like that. But in the same group of kids, we had a really large developmental study. In the same kids that we were studying motor control, we were also studying things like attention allocation, working memory, fluid intelligence, things like that. And I got really interested in all of those, the development of those type of more high order cognitive behaviors.
So how do you define those terms? I know I'm being tough, but this is
Sure,
kind of
no, this is
on the
fine.
edge of what we do from a hearing point of view. So
Yeah, absolutely. Um, you can break it down basically to how we can remember things, how the different strategies that we use to remember things, the different ways that we categorize things. Um, Basically, it's what we think of when we think of how we think. A lot of people don't think of motor control as a how we think type of thing. This
right.
is more how we make decisions, how we interact with if we're given something
How we
and asked to
store
make a decision.
information.
Yeah, exactly. So we were studying all of these different things in these kids, and I was really interested in kind of marrying the sensory motor stuff that I was looking at with these decision making processes. Um, and we were seeing all of these really cool ways that the brain is developing, especially in the context of these things that like little kids don't know how to remember as well as older kids do. And that developmental trajectory was really interesting to me. And simultaneously, I'm going to back up a little bit, but that's where I got into development of these how we think. Um, and I had this. Um, I had this bug in my brain this entire time that I was starting to get into development and these like really complex memory type, attention type things.
Can I ask you a question? Thinking
Yeah,
versus learning. Is there a difference?
thinking versus learning. No. Well, it's about the timeline really.
Right.
So
The thinking is
yeah, thinking
immediate. And learning.
underlies learning,
Okay.
and
Yeah, I
then
was
we
just trying
take
to.
what we've yeah, and then we
Okay.
take what we've learned and we modify how we think. It's a very
Okay.
circular process.
Yeah, there you go. I'm sorry.
And some people, no, it's perfectly okay. And some people use different thinking strategies to learn in different ways, and that is either less or more effective. Some people learn better or more quickly than others, and it really is a cascading process.
So is this where people get those categories of like visual learners and those types of things?
Yeah,
Right.
yeah, it's all about the strategy.
The
Yep,
educators talk about different types of learners.
yep. So some people are more tactile, some are more visual, some are more auditory. What we've really found out is the more different ways you can get it simultaneously, the better. Um, but yeah, some people just latch on better than others to different types of
Well, some people are note takers,
learning.
right? So the
Yep,
actual the writing down of it helps them remember. My daughter's a flashcard
exactly.
girl right now, so she has
Yep. And some people are, that flashcard, but you have to say it out loud. So that internal auditory stuff. Um, but I always had this bug in my brain about backing up a little bit. When I was in undergrad, I was a part-time and then full-time research assistant under Pat Stelmakowitz and Donna Lewis and Kenai Nishi at Boys Town National Research Hospital. And what I was studying was the impact of broadly suboptimal classroom environments on kids with hearing loss, as far as like reading comprehension and oral comprehension. So how well they can understand what the teacher was saying. Um, and oh, I can't. You're muted.
It all comes back to signal to noise ratio in the end, doesn't
Yeah,
it?
exactly. But so I had experience in undergrad, and my undergraduate research experience was, the the very basic data collection, things like that. I wasn't. While I learned a lot about audiology. I would never consider myself an audiologist at that point. But I had studied this group of kids for about 3 years in undergrad, just to, kind of pay the bills, and I was really interested in research. Is what got me into research. Um, but now that I had a lot of experience with cognitive neuroscience and neuroimaging, um, I thought back to those questions that we were asking when I was an undergraduate. And I thought maybe I could apply what I had learned, that no one has really applied that branch of thinking in the context of kids with mild to severe hearing loss. And the question that I was left with when I went to grad school after completing my undergraduate research was, why is there so much variability in cognitive development and language development in kids with hearing loss? And again, I was not an audiologist. I wasn't there to ask the scientific questions. I was there to help the PIs answer those questions. And so fast forward 6 years, I had all this experience with how our brains develop and how our brains think, and the dynamics that are going through in these millisecond timescales that inform how well we learn and how well we understand. And I thought maybe I could apply those things that I had learned the last 6 years to this population that I had studied all those years ago, and maybe answer some of the questions that are still outstanding because no one had approached it in the way that I had, learned how to approach the question as a cognitive neuroscientist. Um,
You were like
so
your own multidisciplinary researcher.
Yeah, that was the idea anyway. But I
Right.
knew that I couldn't do it by myself
Right.
because, again, not an audiologist, not a hearing scientist, not a language development
You needed
specialist.
a
And
little bit
so,
more infrastructure than yourself.
yes, so I reached out to Dr. Ryan McCreary, who I actually knew when he was a postdoc at Boys Town. I was an undergraduate research assistant, so we connected 7 years later, and I said, "Hey, I've got this idea. Why don't we look at those kids that you're so interested in studying? Why don't we look at their brains? Why don't we think about how they think? And maybe that's going to answer some of the questions that are still outstanding." And he had just started this branch of research looking at things like working memory capacity, how big their working memory load could be, and fluid intelligence and executive function, all those things that I was just describing, how people think. He had started looking at those factors to try to dissociate how much of an impact those factors that have nothing to do with language or hearing, per se, uh, influence the outcomes in these kids, such that, even with optimal interventions, they get hearing aids at the earliest they can, they're fit properly. Some of these kids were still not doing as well. And it could be due to these alterations in cognitive function. So I was reading up on his work and I said, this could be a really cool collaboration. And he and I agreed that these gross behavioral tests that we were doing weren't really pinpointing.
Right.
Like, we can say that they don't have as big of a working memory capacity, but what does that mean really? Is it due to how well they can remember the things that they're trying to remember? Is it the fact that they couldn't store it in the first place? Is it a matter of, could they store it fine, but they can't retrieve it
Well,
to
once you understand that, you
remember?
have better strategies to solve it, right? Until you understand why it's a problem, you can't really address it to get better outcomes.
Yes, exactly. And I work with a really, fancy neuroimaging device called magnetoencephalography, which is a relatively rare neuroimaging technique that can give us the complex brain dynamics with like millisecond temporal precision and millimeter spatial precision. It's the best combination of spatial and temporal brain function that's currently available. And so I
It
said,
maps the
maybe.
function of the brain based on this stimuli by associating it immediately with the stimuli in the right location, correct?
Exactly.
That's great. That's how many of them
Yeah.
are there around?
There are, I think, about 40 in the United States now.
Wow, that's not that many.
And not only, I would say, less than half of them are research dedicated. The majority of them are used for like clinical mapping of epilepsy and functional mapping of prior to tumor resection for neuro-oncology patients, things like that.
Okay, interesting.
Um, yeah, so I thought, if I can get these dynamic brain maps that can break down different aspects of memory and attention, such as, like I said, when you're processing the stimuli versus when you're trying to maintain it in your memory store versus when you're trying to retrieve it, I could pinpoint exactly which stage of these cognitive processes kids with hearing loss might show differences, which could really help us pinpoint the underlying cause of some of the variability in these kids.
That's really
So, so that's where our collaboration started, and we've been working together for 3 to 4 years. I also work with Dr. Beth Walker at the University of Iowa to really pinpoint some of those hearing aid associated factors that might give rise to variability in brain dynamics.
so. Yeah, it's so. What are you finding in terms of what particular? I mean, I know this is really broad based, but in terms of general findings, in terms of this stuff, what particular things can you or can't you map to rehabilitating the hearing? Like, do people get a bigger working memory, or what happens?
So what we're finding, and all of the results are still coming in. We've just published our first set of findings, and the rest of the stuff is either under review or still
Take
working
time.
it out.
I suspect this is pretty laborious analysis. That's what I'm suspecting.
Yeah, but we're really, really excited with the results that we've gotten so far. We, broadly speaking, what I would say is that um, none of our groups are significantly different behaviorally, and that's really important. And that's something that's kind of where I try to hit my sweet spot as a scientist, because I really like to see um, how brains are different in order to perform the same way, so
Right.
that in these really controlled experiments, they might do things similarly behaviorally. But if I can see that there are differences in brain activity, you can assume that once we let people out in the wild where there's a bunch of distractions and multitasking and things like that, then any of those differences that we're seeing in the brain might give rise to decrements in behavior in the real world. Um, so what we're seeing is, despite no difference in behavior, we see that when kids who have mild to severe hearing loss are performing a visual-based working memory task, they are utilizing more regions of their brain during encoding and maintenance. But so encoding is when you're trying to, the stimuli are there and you're trying to absorb them. Maintenance is when they go away and you have to remember them. What we're seeing is there are these very phase-specific differences in brain activity, such that during encoding, when you're trying to initially store those stimuli, um, they use the same brain regions as kids who are normal hearing, but they also use these additional regions on the other side of the brain, which is from the healthy aging literature, from the literature involving other disorders. If you use the same brain region on the other side, that tends to be what's considered a compensatory response. So, in order to perform at the same level of their normal hearing peers, these kids are using more brain area, so their brains are less efficient processing. And even cooler is the amount that these kids are using those additional brain regions. The better they are at compensating, the better their verbal intelligence. So the better they're able to compensate for these changes that need to be made in their working memory systems, the better they do on verbal intelligence.
This is almost, I mean, maybe I'm wrong, but it sounds like a measurement of plasticity, right? Like the
Yeah,
ability of the brain to adapt. You're actually demonstrating it in real time and showing where the actual plasticity is of the brain.
exactly, exactly. And the hard thing with plasticity is it's really good when you're able to compensate and you can utilize more brain regions more efficiently in order to perform a task. But the issue lies when, if you have to use more brain regions to perform something as well as normal hearing peers, for example, at some point you're going to run out of resources.
Right? There's
You're
only so much
going to
CPU profile.
exactly. Yeah, and I term that an exhaustion of neural resources. So you have to use more brain regions to perform at the level of your normal hearing peers, but then at some point you're going to run out of those additional brain regions and you're going to start to decline, where those normal hearing kids still have those additional brain resources. So in the harder tasks, they might also use those compensatory regions, but they didn't have to start using them until it was more complicated.
So the question then becomes, is there, I guess this is a little harder, like if they're using those other regions, do they lose some other function?
Possibly. So the things that we're looking at now is things like multitasking or attention reallocation, or um, you know dual task paradigms where they have to do two things at the same time.
Yeah, because
And
when I model to patients, the brain burden of hearing loss, right? Because they use speech reading and contextual processing to compensate from a brain point of view for their hearing loss.
mhm,
That's extra work, right? So then the question
exactly.
is the cognitive deficit from that, deprivation of other processes, right? So
Yeah,
actually, I assume you're mapping eventually, somebody might map that and figure that out.
yeah, yeah. That's the goal. But then the other aspect that we are looking at, so we wanted to look at just general, what does hearing loss do to the brain on a group level? But then we're also really interested, like I said, in those individual differences. So there's a lot of variability in outcomes of kids with hearing loss. And so what we also found is we took just the hard of hearing group and we did what are called whole brain correlations. So we take activity in every region of the brain in little 4 millimeter chunks, and we correlate it with different neuropsych, different audiological variables, things like that. And what we found was all of these regions that showed this compensatory increase in activity weren't as utilized when the kids wore their hearing aids more. And there was kind of a sweet spot, actually, where if kids wore their hearing aids more than 8 to 10 hours a day, they had a relative normalization of activity. So their activity no longer looked different than normal hearing peers.
Well,
And
it's
that
a
was
strong
controlling
argument
for
for
a degree of hearing loss and age and all sorts of stuff. So
strong argument for consistent wearing.
exactly.
I have, it's usually older patients who say, well, I only put them on when I need them. It's like, I'm not sure I understand exactly when that is, but, right. And so that's obviously in the pediatric literature is definitely supporting consistent wearing of amplification throughout the day. Right?
Exactly. And we've seen this exact same trend in different groups of kids with hearing loss extremely consistently. It's like a scientist's dream how consistent this is, where you have this pathologically high levels of activity that aren't typically seen in normal hearing kids. And all of that gets suppressed with greater hearing aid use. And again, it's that sweet spot of at least 8 to 10 hours a day. And that includes things like we have a fluid intelligence task, which has nothing to do with language. It's all about relational. If you take two objects, how are they related? How are they not? Even in tasks like that traditionally aren't seen as something that kids with hearing loss have an issue with, we still see these aberrancies in or alterations in brain activity that are completely normalized with consistent hearing aid use.
That's really cool. That's great stuff.
Yeah.
I mean, it's interesting because as you're talking, I'm thinking about, we used to talk about, or we still do, that social context matters, right? Like, parental support, all that stuff. So those are like external contexts, right? Mm-hmm. Now you're kind of measuring the internal contextual things that determine outcome of hearing. Your imaging modality is magnetic resonance. Is that right?
Magnetoencephalography, MEG.
So can you do that with cochlear implants, or does the implant itself distort the results?
We can't put kids with cochlear implants in our instrument. It's not that it's not like MRI or magnetic resonance where it is a magnet, and so that it's a health concern. It's actually a concern to our instrument, not the participant. Our imaging is completely non-invasive, but the sensors that we're using are yeah. The signal that we're measuring is 15 times smaller than the Earth's magnetic field, and so
any disturbance.
Yep. So if you put a magnet close to that sensor,
well, we see that in MR too, right? It's not just the safety of the patient, but you see a distortion of the image around it. So you're essentially getting distorted images, so you really can't do it. And that'll be, that'll be interesting. Does metal do it as well as magnet, or just metal?
It does. It does. Any ferromagnetic metal will do it. So like surgical implants and things we don't have an issue with those. It's just the ones that have a magnetic moment.
Yeah. So
that said, we have at Boys Town. I just moved to Boys Town in January of this year to help open the Institute for Human Neuroscience, and we are currently the only location in the world that has two of the next generation MEG instruments that have they're called armor sensors that we haven't tested it yet, but they are supposedly have 30 times the dynamic range, which would allow us to put people in that have relatively large magnetic artifacts and still be able to record them. So the hope is eventually we'll also be able to look at CI patients.
Yeah, that's certainly. I mean, obviously they're not the only ones, and you can get a ton right out of it, but that's a kind of an interesting area. And so I assume this work, your Boys Town, you're doing predominantly pediatric work, but is there evidence showing that what happens on the other end of this? In other words, can people reverse it, get the brain plasticity, stop using the intervention, lose the brain plasticity, and then get it back? Does that work? Or
so we're not quite sure how it normalizes. So I'm really interested in looking at those like the brain is changing on a developmental trajectory in the kids that I'm looking at. So the kids who are normal hearing are also showing these changes with age, and then it kind of levels off um,
When does that
around.
happen?
It depends on the construct. So basic sensory stuff is super early, things like 7, 8 years old. But then when you're talking about these like working memory or that relational intelligence, things like that, that's when you get up into the 17, 19, 20 years old before we get really, really good at it. And then it starts to level off in the 20s.
Are there any exercises that you guys have measured to show that it can be improved? Now I'm thinking from my own context, right? They always tell you do Sudoku. I mean, that's always been one of the things. Like, when you look at neuropsychology testing, it's fascinating. But once you get a diagnosis of cognitive impairment, the real question is, well, what do I do about it? And so it'd be interesting to
Exactly.
see if there are particular exercises or things that can help these. And I guess you guys will see this, what things can make these skills better.
Yeah, and that's kind of the idea of
A workout
Uh,
program.
yeah. We're that's what we're hoping to do is not only so we're finding these just group wise differences, single time point type stuff, but what we're hoping to do is take this longitudinally in the kids, and then back to your original question about how cognitive decline happens in later age. One of the biggest predictors of cognitive decline is hearing loss,
Right.
and it's not clear what that bidirectional relationship is. Um, but it's almost like the same developmental trajectory differences that you see in kids happens.
In
It's
reverse.
perfectly mirrored in old age. And so the hope is since we are able to see these plastic changes with things like hearing aid use, and like you said, things like cognitive training, Sudoku, things like that. What that's doing is it's teaching your brain how to be more efficient. And so, in the case of cognitive decline, you have to use these additional resources. You don't have as many resources as you used to, just due to cell death, things like that. So by increasing the efficiency of your brain, you don't have to use those compensatory resources as much, and then that exhaustion of neural resources doesn't happen as quickly. And so we see that in the cognitive decline literature. How it's related to hearing loss, we're not quite sure. Um, but on the developmental side, we're hoping that the focus has been really on, restoring access to speech and restoring, making sure you have adequately fit hearing aids through development, things like that. But one of the things that I'm really curious about is if we can make these other cognitive patterns that people have more efficient, will that help them, compensate for any of that suboptimal stuff that they may have in those other domains? Um, so the work that I'm working on now is looking at differences in difficulty of cognitive tasks and where we see that inflection point where they start to use those compensatory resources, and then using that as a starting point for training, whether that be give the kids a worksheet and have them work on these different tasks just for fun in their evenings or what have you. And then the
Brain
other
gym.
aspect,
You give
yeah,
it a brain
exactly. And then the other aspect is, we always have to bring it back to language. So language deficits are the biggest issue in kids with hearing loss. And so if I can relate that back to, um, you know, language processing and get at that construct as well. So those are the two things that I'm working on now, are taking things longitudinally and then also looking at those nuances and whether we can work on those constructs that we find to be different.
Yeah, so actually, what comes to mind is, there's a relatively nascent field of kind of brain games, where they're trying to give people, some of them are on NPR and different things. Be interesting to see if in the children, if you had them, because I mean, you could think of it like calisthenics or workout regimes, right? Like, short of you don't want kids lifting weights too early because they'll injure themselves, but short of that, there's no reason they can't do the same things that adults are trying to do to reverse processes or prevent processes. So be interesting to see if any of these brain games out there, Lumosity or those things, actually help the kids increase their capacity, right?
Yeah. Yeah, and it could be something as simple as not even just brain games, but just teaching them if they have differences in attention, teaching them different strategies that they might not naturally do. But we know that they have to pay attention in a more, it's harder for them to pay attention in a suboptimal auditory environment. And so giving them strategies, say, hey, have you considered doing this? And it's not even something that they have to, do these brain games. It could be something that they could do from, a therapy standpoint, where they learn these other strategies that we know that normal hearing kids are using that they might not naturally do because of their, necessary compensatory behavior. So
Interesting.
just teaching them new strategies and seeing if that helps as well.
Yeah. Well, I mean, as simple as the kind of bread and butter things we do, preferential seating, right? I mean, that's
Exactly.
actually, that's a simple, self-advocacy thing. But you're talking about maybe a more specific prescription where you can actually tell them these specific things will help you. Yeah, that'll be, you'll have that done by next week, I assume.
Oh, yeah, for sure.
I assume the data collection is relatively arduous. I mean, I don't know, but I assume it's time consuming.
Yeah. I mean, honestly, our kids are rock stars because I have, all these great, fantastic scientific ideas about how we should do all these data collections. But at the end of the day, we have these kids doing 6 to 8 hours of testing for me to try to prove a point. And so, and it's incredibly boring. And so really I got to give credit to them and my staff for getting the data. More than, like I said, I have the easy job where I have these ideas and then, can you do this for me? And the kids are great. The families are great. My staff is great. So
That's because you're at the right place, right? With
exactly.
So where do you see this going in the next 5 to 10 years? These types
We're
of
hoping,
and testing them out.
yeah. It's still such in its infancy, and the results that we're getting are so exciting, but they're also, it's almost like we're seeing everything is different in the brain. And so really pinpointing what
Where do you put your efforts?
exactly,
Right?
exactly. I mean, it's great that, we're able to quantify a lot of this stuff is just lack of quantification where we can say, yeah, uh, you know, Joey has a really hard time paying attention in class, but I can say, yeah, that's because when he, has to reallocate attention in this very structured environment, he has to work harder in these brain regions. So maybe let's work on efficiency in these certain ways based on what I'm seeing in my data. So it's a really cool way of quantifying the biological mechanisms underlying these things that, parents otherwise just complain about or kids otherwise complain about.
Well, maybe you
But
need to reverse engineer it, right? Figure out what are the things that are most attainable in a reproducible and simplest way, and then see if those work the best. Because, there might be a very sophisticated training, but if nobody can deliver it on a scalable way, it's great, but it's pretty hard to deliver, right?
exactly. And it's also one of the things I'm working on is just using what we have now, what we've been prescribing kids. And does amount of does your speech intelligibility, how well your hearing aids restore your access to speech? How much does that matter as much as hearing aid use? And we do speech and noise tests all the time to as a good metric of how well kids are performing, but is that really the best measure from a biological standpoint? So
Well,
pinpointing the test and all of those things
testing
is
is a
also
huge deal.
exactly. So right now we're kind of in the identification stage. Which things can we do? And the lowest hanging fruit is obviously just optimizing things that we already know help kids. How can we fine tune those? But then also, like I said, I'm incredibly biased as a cognitive neuroscientist. I want to see what other, cognitive therapies can we give these kids? What can we send them to a school psychologist and tell them, you need to work on selective attention. You need to work on working memory. Here, play these games. Anything that we can do that we haven't really pinpointed could be the best. And like I said, I not only look at the results of, behavior, but I also look at those sub behavioral differences to try to pinpoint, okay, here are the biggest differences in the brain, which means in the real life, in the real world, is this where these differences are actually going to show up, even if they never show up on a clinical scan because you're in this nice quiet clinic doing all these standardized tests. So really I'm at the identification stage, which is really exciting, but it's also really,
Overwhelming.
arduous. Yes.
Yeah,
But the idea in the next 5 years is to take that longitudinally again, see if we can improve these constructs, see if we can optimize the brain and not necessarily make them, more like normal hearing kids, but make them best for the kid. So that's kind of the goal anyway.
interestingly, I was just thinking, Ryan was talking about how, he sees people who are at the lower part of normal who have functional impairment. So have you done, is there a fall off point? In other words, based on thresholds, or is it linear? As the thresholds get worse, the compensatory mechanisms go up. Do you see what I'm saying? Do they do well and then fall off, or is it kind of a linear relationship?
Kind of both. So, and that's kind of where I get at that exhaustion of neural resources, right? So you get more and more, you get this linear increase in activity in these brain regions that are associated with behavior. And then it comes a point where you can't increase activity in those regions anymore. Those regions are spent. And so then you use
water. At some point,
exactly. And so it's linear up to a point, and then and the linear activity stays linear while the behavior starts to asymptote and then decline. So the more alterations they have in their brain, up to a point, it's good. It's compensatory. It's good for them. But at some point, there's just no ability to compensate, and that's where that behavioral decline happens.
Are there external factors like IQ or other things that determine the overall capacity? I'm just wondering if there's any prediction from an external measurement, or is it you got to put them in the scan and see?
Of the brain capacity?
Yeah, or the compensatory capacity.
I think those are actually interchangeable.
Yeah, because it's based on overall brain capacity, how much you can compensate, right?
Exactly. And I would definitely not say that kids with higher IQ have the most efficient brain.
I was just trying to figure out if there's some sort of correlation with some sort of externally measurable.
Yeah.
It's a common measure, like blood pressure.
Sure. And yeah. And that measure of verbal intelligence that I was talking about earlier, where the ability to compensate correlates with verbal intelligence, that is our IQ test. It was just a subset of the verbal IQ. And so, at some point, there is a direct relationship between your ability to compensate and your IQ. But like I said, I don't want to go so far as to say, higher IQ people just have more efficient brains, lower IQ people don't. It's a dynamic interaction.
It's also dependent on the test. Right?
Exactly.
How well you do on that particular test is not necessarily predictive of all function. That's for sure.
Yeah.
We like one measurement. That's kind of the bias of people. I think they like one.
Absolutely.
There's oftentimes not one number, especially what you're talking about right now.
Yeah, there was a grant mechanism that was out just to determine whether one metric shows up the same in the brain, regardless of whether it's auditory or visual or tactile or anything like that. And all the cognitive neuroscientists in the back are like, of course, it's not the same. It's it's dependent on your environment and what you're absorbing. And the goal of my lab in general, the name suggests cognitive and sensory imaging. I want to see how any alterations in how we perceive our external environment, whether that be, due to natural factors such as hearing loss, vision loss, things like that, or due to things like, the cocktail party phenomenon, where you're in a really loud environment, you have to pick out things in your environment. I'm really interested in seeing how our sensory perceptions relate to those things that we always thought were independent of sensation. Right. Things like IQ and things like, fluid intelligence, working memory, things like that everyone has always said, well, your working memory capacity is 5 plus or minus 2, regardless of whether you're trying to remember what you need at the grocery store or these 5 tones. And so I think
not that simple as the answer.
Exactly. Yeah. And so I'm really interested in seeing that interaction and seeing if we can't alter our sensation, can we alter our cognition, and to optimize both, really. So
you're muddying the waters for people. It makes it hard.
I am. I'm making good trouble, right?
Right, right. Well, I mean, you're asking the questions in a different way so people can, really get more granular. Because if it is one number, then that's fine from a study point of view.
Sure.
But from a practical application point of view, it probably doesn't take you any closer to getting tools or tactics or strategies to change, right? And so fundamentally, if you want patient outcomes to change, it actually probably has to be more granular to be able to come up with any sort of intervention to get that change rather than, well, you have this number and that's it. Sorry, too bad, too sad. That's not really going to get anybody.
Exactly. And I've been really fortunate to work with such good collaborators that have such a different skill set than me, where I, look to them, look to Ryan and Beth to see, what are the practical problems that people are having, because I can, think till I'm blue in the face in my office about, the relationship between working memory and language in kids with hearing loss. But if it doesn't matter practically, then why would I look at it? I need to know, from an audiological standpoint, what are the difficulties that people are having, and then I can approach it in a way that people that haven't done, decades of cognitive neuroscientists or um, neuroimaging have ever had the capability of looking at it. So
Signal to noise improvement ratio exercises. That's what people want. Right? They want to hear
it's
better
true.
in
It's true.
restaurants. If there
It's
was like
true.
a prescriptive thing, like you could do these exercises, I mean, there'd be a ton of people who want them. And
I
again,
mean,
I don't. It's going to not be that easy, as you know.
I wish it was. I mean, in
Me
fairness,
too.
I would also love that
Yeah.
if we could boil it down to that.
Well,
But
I
it would
thought it was
also
like,
make it so I'm out of a job. So
wow, you just study something else.
yeah, that's true.
I mean, you have a natural curiosity. I think it would just take you somewhere else, but I don't think you're going to be out of a job. So, well, this is really great stuff. I can tell you, I'm going to be circling back in a couple of years to see where this all is because it is fascinating and it's really, the practical application of the convergence of the fields. And you're right on the clinical edge. You're not kind of dragging people into your lab who have nothing to do with the clinical applications of this. It's really great. So
Thanks.
one of the questions I love to ask people is say you're getting an award, a lifetime achievement award. Who would you thank for helping you get to where you are today? Who are those people?
Sure. Oh my gosh, I have had the best mentoring history, I think ever. The people who got me into audiology originally, Dr. Kanai Nishi, Dr. Donna Lewis, Dr. Pat Stomakowitz, who's a legend, um, really got my curiosity in research. Pat was the first person who told me to consider going to grad school for research and that I really had a knack for research.
That's great.
I had never considered that at the time. And, imposter syndrome is real. And so to have someone who is such a big, like I said, a legend in the field of audiology tell me that I had a shot. I cannot thank her enough. May she, rest in peace. She was a force in the field
That's
and we
great.
really miss her. And then Dr. Tony Wilson, who took a chance on me in grad school. So I distinctly remember in my interview for a position in his lab, he asked, "Do you know what MEG is?" And he was just getting ready to explain it. And I very nervously said, "No, but I'm willing to try." And, I knew nothing about neuroimaging. And he really, I was the first grad student in his lab, and he really took me, and taught me everything that I know. And then, of course, most recently, Dr. Ryan McCreary, Dr. Beth Walker, and then Dr. Lori Leibold, who have provided just immense amounts of mentorship. They took someone who was very honest in saying, I don't want to sound like an idiot to the audiology community, but I'm really interested in this population. Can you help me not sound like an idiot? And they hopefully have done that and more. Where I am so lucky to work with currently world leaders in their field, and they've always been available to answer my questions. They've always been open to new ideas, and it's just been a dream collaboration to be able to work with all of the hardworking, brilliant people that I work with. It's really amazing.
That's great. Awesome group. And yeah, that sounds like a wonderful mentorship to get people to help you move along. That's really wonderful. And
Yeah.
so the last question, what's your favorite sound? We are in the world of sound. So what is your favorite sound?
That's the easiest question around, and I'm sure you've gotten it a lot. My kids' laughter is the best sound in the entire world, hands down.
That's awesome.
So, yeah.
So this has been great. If people want to get a hold of you, how do they get a hold of you? How would they reach out if they have a question or an interest or anything like that? LinkedIn?
I have a professional Twitter account. I have my lab's Facebook page, the Cognitive and Sensory Imaging Lab at Boys Town National Research Hospital. Our lab website, any of those avenues. I'm happy to take any questions.
You're Googleable, if that's a word.
I am very Googleable, and my name, luckily, is not very repetitive.
Yeah. I don't think you're going to get
in the world
8,000 of them coming up, right?
Exactly.
Well, this has been great, Beth. Everybody, this has been Dr. Elizabeth Heinrichs-Graham. She's the director at the Cognitive and Sensory Imaging Laboratory at Boys Town National Hospital. This has been a great interview with incredibly fascinating stuff. I could talk about this for on, but we both probably have other things we have to do to get the day going. But thank you so much for coming on. This has been wonderful. And I will look forward to checking back with you to see where this has all gone. Thank you so much.
Absolutely. Thank you again for the great conversation and for the invite.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.